Welcome to our North Florida AIDS Education and Training Center's webinar, Patient Activation Dynamics, Cultivating HIV Self-Management Skills. My name is Taryn Buckley. I'm the project manager here at the North Florida AETC. Before we start today's event, I have a couple housekeeping items to go over. If you're listening in by computer, just make sure your speaker button's turned on. If you're listening in by phone, we should have had you come in with your line muted, so you shouldn't have to worry about that there. Today's event is scheduled for 1 hour, including question and answer session at the end of the presentation. If you need proof of attendance for your employer or if you need a certificate for CE, you can do that by completing our evaluation, and you'll receive a link to that evaluation before the webinar even finishes. You'll get a link to the email address that you've registered with. You click that, fill that out, and you'll be able to instantly get a certificate of completion that you can use for your employer, or we will report directly to CE Broker for those who have credentials with Florida Board of Nursing or with the Florida Board of Social Work Masters and Marriage Family Therapy. If you have any questions for the speaker at any time during the presentation, you can use this Q&A pod in the very bottom middle of our web room. Your submissions that you type there will go directly to the speaker or to me as a host, not to any other participant. So you'll type a question in, and you might see the question there, but no one else can see that question except for you and the speaker and the host. So if a question comes up in the middle of the presentation, that's probably the best place to put that there. We'll answer those questions at the conclusion of the presentation. Any unanswered questions that remain due to time constrictions will be addressed via email to the webinar participants. A copy of today's PowerPoint presentation can be downloaded from the Files pod, the bottom left-hand side of the Adobe Connect room. You'll see there are two things in there. We've got the Patient Activation Handouts PDF is a copy of the slide set for today. And the Patient Activation Tool Information links are a couple of helpful links that our speaker is going to discuss with you today. Just wanted you to have a handy sheet with you, and she'll go over that a little bit more. So without further ado, I'd like to present our speaker, Ms. Deborah Cicero-Seifer. She's a nurse consultant with the North Florida AIDS Education and Training Center, a partner of the Southeast AETC Network. Having more than 35 years of mental health and chronic disease management experience, Ms. Cicero-Seifer has provided care and treatment to individuals living in the rural mountain communities of Tennessee, North Carolina, and Virginia. Additionally, she served as assistant professor of nursing at the University of the Virgin Islands from September 2007 through July 2012, where she taught psychiatric and geriatric nursing. Ms. Cicero-Seifer has coordinated numerous clinical research studies and published articles in the field of tobacco intervention, cessation, and pulmonary rehabilitation. From 2012 to 2015, Ms. Cicero-Seifer served as the project coordinator for the Florida Caribbean Telehealth Education Training Center, a faculty member with the Florida Caribbean AETC, and a coordinator of the Expanded Testing Initiative. In 2015, she began working with the North Florida AETC. In her 12-year history of working in the field of HIV/AIDS, Ms. Cicero-Seifer has presented numerous educational sessions and workshops on topics such as engagement, linkage to care, patient activation and motivation, behavioral health screening instruments, cultural leveraging to promote engagement, health disparities in health access, talking about sexual health, HIV testing, and motivational interviewing strategies to promote health and behavior change. So without further ado, I'd like to introduce Debbie to you all. Thanks for being with us here, Debbie.
Good afternoon, good morning to some. I know there may be some time changes going on for folks, but I really appreciate the opportunity to be with you all today for the next hour as we look at what does patient activation look like and what factors need to occur in order to have the best situation for patients to feel and be activated in their own care. And this is of great interest to me because in my work I see that we struggle as providers in helping our patients, partnering with them, to find out where they are and what the possibilities are for where they can go with their own disease management skills. I have prepared many slides for you today that I hope you'll be able to use not only today but in the many weeks and months to come. I have no disclosures to make to you today and have no commercial entities with whom that I work. The objectives for today's program are really to define some important terms, the words empowerment, activation, engagement, and self-management. Discuss how unconscious biases and negative attitudes influence patient care delivery and patient engagement and, of course, activation. Third, looking at how to describe the physiological as well as the social emotional impacts of stress and the influence that stress plays in people's lives who live with HIV and other comorbidities. And lastly, I hope that we can identify as a group the cultural responsiveness and inclusiveness that needs to occur, those strategies that can be used by organizations and by individuals to help empower, engage, and activate individuals living with HIV. I'm going to start us off looking at the care cascade. This is a 2014 version, United States, from the CDC, and many of us are very familiar with this, and we see the drop-off. And actually what we would like to see is the mirror image of this. We would like to see very few people involved in getting diagnosed with HIV and many, many people suppressed, where their viral loads are suppressed. And the biggest drop-offs in this care continuum result from what the literature provides us with the information that there are inadequate supports to link, retain, and re-engage and support individuals to remain engaged in care. And so the purpose of this program is to really look at what those factors are and how do we create relevant strategies to change this around. The evidence that drives antiretroviral therapy adherence and viral suppression, a key study was done in 2014, and that finding showed that contact with providers, engagement with providers was key in getting higher numbers or higher rates of viral suppression in our patients. We know this. And that did improve patient outcomes, not only HIV related, but just basic health related outcomes. So that was an important key finding. This is another visual image that I really like because it shows, this is from HRSA, it looks at how do we look at the spectrum of engagement in care. And we go from those folks who are not in care to those folks who are very engaged in care. And that is a huge span. There's people all over this continuum, and those are individuals who are unaware of their infection all the way to the other end of the spectrum where people are fully engaged. They're fully involved in self-management, and they are fully engaged in their care so that they're activated. They're doing the heavy lifting to do the work that is required of them. And this would be in any chronic disease. This same scenario or continuum could be used to look at diabetes, obstructive lung disease, other chronic illnesses. So now let's look at some of those terms I promised that we would go over. One is empowerment. And empowerment is a process through which people gain control or feel that they have control over decisions and actions affecting their health. And this definition comes from WHO in 1998. If you follow with me at the green circle, these activation, the term activate, or excuse me, engage, that is an action that individuals take to obtain the greatest benefit from the healthcare services that are available to them. And this is an important term. This is about how individuals do the work to come to the provider's office, to go to meet with the case manager, to go to the counselor, or how they receive these services, whether it's in a federally qualified healthcare center, and a one-stop shop, if you will, or if it's one piece of each of these services one by one. It looks different for every client. The other terms we want to look at are the word activation, which I'm going to be using a lot and have used already. And the terminology by Dr. Hibbert, the term she has used, and she's from the University of Oregon, has done a great deal of work on activation, which I will share with you. Her definition of this word is an individual's knowledge, skill, and confidence for managing their health and their health care. And this is an important term, and I'm going to keep referring to it over and over again. The last term I want to bring to your attention today is self-management. And those are those tasks that individuals must undertake to live well with illness, and includes having the confidence, the individual's confidence level in dealing with the medical role and emotional management of their chronic disease or chronic diseases. This comes from the Institute of Medicine in 2003. And there is a process here. Is this process linear, where in order to get to self-management, a client goes through all these other processes? Yes, but people, again, just have to go in and out. Sometimes they feel less empowered because something occurs for them that has them feeling less confident in their abilities to partner with their healthcare providers. So again, people come in and out of each of these different terms. There's a continuum, if you will, for each of these terms. And we believe that with having the empowerment and the engagement and a little activation, you can reach a high level of self-management. I know many clients who are self-managing, but maybe at not the highest level, because they need a little bit more empowerment, or they need a little bit more engagement and a little bit more activation. So if you will, maybe we need to look at this like a recipe. A little more salt. Let's add a pinch of salt. Let's add a little flour. Let's add a little leavening agent. Again, looking at this as a recipe, which is something that I do as an analogy when I'm talking to clients, when we're talking about the process of learning how to take good care of yourself and protecting your health, the health of this body that, to my knowledge, we only get one of, and we want to take very good care of it. So today we're going to look at models of care that address patient care and their engagement and their activation. Critically look at these terms and how do we get there. We're going to look at tools, we're going to look at interventions, and we're going to look at practice transformation, or the opportunity for. The engagement and care components, as I had discussed with you, very important. A lot of this is structural, it's organizational, and it involves the kind of providers and team members we have in our organizations. How well do we work together? Engagement and care components include the structure of the clinics, the culture that's going on there, the provider approaches, ancillary services, personal and cultural occurrences. Is there something in the waiting room that shows that the client is open to providing care to all individuals, no matter what their creed, what their ethnicity, no matter what their sexual orientation? What are the financial issues involved in engagement, the medical issues, coexisting conditions, and again, how do we measure engagement? So there is a readiness or retention readiness indicator tool that Dr. Hibbert has actually put together from the University of Oregon. It is not readily accessible, the actual tool, but I can tell you that there's a lot of information about it, and there are ways to reach Dr. Hibbert and her team as an organization or even a provider to find out more and to see if this tool might be of interest or use to you. But it does is it looks at the 4 components. This is called the RRIT, or the Retention Readiness Indicator Tool. And it was created based on findings in research indication of why the most vulnerable populations fall out of care. So this tool was created from a large amount of data collection by Dr. Hibbert and her team. And I can fully recommend that this is a very interesting read when you go into the literature and what the University of Oregon is doing with this information and this tool. The next thing I'd like to bring to your attention, which I'm very excited about, is the O'Neill Center, who's developed what we call the Interactive Care Model, or the ICM. There are 5 key objectives at the O'Neill Center for each clinical encounter that their clients receive at the time they engage in the process of becoming a patient at this center. One is assessing the patient's capacity for engagement. So there we have a measurement going on, and I'll share that with you in a minute. Then we have an exchange of information and communicating choices with the client, finding out what the client is there for, finding out what's high priority for that client, and communicating what choices are available to them as they step forward in partnering with providers at the O'Neill Center. Third, the planning that goes on between the patient and the care team. Fourth, determining mutually agreed upon interventions. What's going to happen moving forward? What is the client going to do? What are the providers going to do? What is the team going to do? And how will this be evaluated? Of course, number 5, what is the effectiveness? What did these interventions go? Where did they get the patient to? And what work needs to be done to either go further or to maintain what has been accomplished? The interactive care model is grounded in systems theory. It's a model, again, developed by researchers and reviewed by clinical experts, informed by feedback from clinicians, patients, and again, patient data was collected on this. That means that the consumers were involved in creating this tool, and that's why I'm so excited about it. Early evidence shows that patients who are more involved with their care have better outcomes and lower health care costs, which obviously is important to everybody sitting at the table. The Patient Engagement Index is the tool that is used at the O'Neill Center. They launched an 18-item tool that has been worked on with the Barrel Institute of Patient Experience, and it was released just at the Barrel Patient Experience Conference in Denver, Colorado, just this past March, in a presentation that was titled Person Engagement Index, Measuring a Person's Capacity to Engage in Their Health Care. And the next step is they're going to release this tool not only for their own use, but for use by other organizations and clinics to use this in a process of improving engagement and hopefully improving patient activation. A way of measuring where is the patient starting at in terms of what is important to them in meeting their health care needs. So with that being said, these are pretty exciting tools that are being used and that we have access to. Again, Dr. Hubbard has the patient activation measure. It's called the PAM. The premise of this tool is that patients will not follow treatment goals that they do not believe they can follow or that compromise other priorities they may have. Could be social priorities, could be cultural, could be religious, many different priorities. And so this tool has been used to tailor care and intervene to individually meet patients' or clients' needs. There is a short form of 22 items. Again, you need to connect with Dr. Hibbard in order to continue to be able to access this tool because it's not readily available. The patient activation tool, I think, also is another tool that we can look at to help us in working with our clients who are HIV positive. So let's take a breath for a minute and step back and look at patient engagement and team-based healthcare. We've looked at some tools that might help us measure where we are starting with our clients and then periodically measure how we're doing and how the client is doing in terms of their activation level and engagement in their own care. As you can see by this visual aid, someone is not on the team. Well, that someone is the patient. When the patient walks away from care and the team is doing more work than the client, then we definitely have a problem. So how do we intervene before the client walks away? Who isn't engaged in care? Well, many of the people that walk away from care are individuals, as we know, 4 key subpopulations of individuals living with HIV include MSM of color, African American and Latino women, youth under the age of 24, and transgender people. So we know we already have identified individuals who are most likely a high risk for walking off the team. Remember, they are part of the team. Having a care management team conference and having the patient not there is not a team conference. I created this because it reminds me that the care continuum, the HIV care continuum, is about individual people. And as you can see, I've used little emojis to show that everybody's at a different spot. Some people are very sick when we meet them. Some people are angry. Some people are surprised and overwhelmed, like me, how could this happen? And then some people are sad and depressed. And some people are contemplating, what do I do now? And as we get further along the care continuum, we recognize that to be that happy person that feels empowered and activated and feels like they're taking good care of themselves, it takes a lot of work to get there. And that the continuum is really real people with different health journeys. And that's what we're focused on in the trenches. And I know everybody on this call knows what I'm talking about. And I appreciate the work that you do because I'm in the trenches with you, and I know how frustrating it can be when our patients sort of walk off and we're trying to find them and we're trying to say, hey, look, this is important. We care about you. So let's take one of these clients. And what is their individual journey? I introduce you to the healthcare journey of, I've selected the name Kay. And this is Kay's story. Kay is a 19-year-old Black African-American male who is MSM. Kay's preferred pronouns are Z, here, and here's, and herself. Kay tested positive for HIV at a community health center in rural Florida in August of 2016, so about a little less than a year out. Kay was raised by the maternal grandmother was involved in the care after Z's mother died when Z was 6 years old, a little guy. Biological father was shot and killed when Z was 11. Z's grandmother died when Z was 16, after which Z engaged in couch surfing, which is a type of homelessness, and prostitution. Viral load at the time of HIV diagnosis was 8,800 copies per ml. Kay refused antiretroviral therapy in August of 2016. Z was lost to care for 4 months during the winter months and returned to care March 1st, 2017, diagnosed with gonorrhea. There's a history of heavy alcohol use and some cocaine. Z works at a local convenience store right now. Healthcare team describes Kay as being a quiet, young person who appears anxious in the clinic. Okay, so now we all have a visual of who we are working with and the journey that this individual has experienced on some level. So let's have a think tank. Let's have a little bit of a case conference. Here's the epilogue. Kay goes to a different community center clinic 75 miles from the previous one after being out of care for 4 months. Z missed a second appointment to indicate HIV treatment and care. Today, Z has an untreated sexually transmitted disease, gonorrhea. What needs to happen at this clinic visit? And we're going to bring this question up for you. What needs to happen here so that we can address Kay's health issues? And that's recent disconnect that Z has had from the receiving and engaging in HIV treatment and care. So Kay is not receiving care really and is not engaging in treatment and care, but comes because of gonorrhea now. So we now have a compounded problem. So here you can write your answers and they'll pop up for all of us to look at. And hopefully you're at a computer or someone in your group is at a computer. If you're in a group setting, just call it out to the person at the laptop and type in any thoughts you have, a few words, if you will. Okay, so someone here on our team is suggesting that we assess Kay for appropriateness of test and treat. Absolutely. Absolutely. If this is something that our clinic can have either on site or connect the client to this, wonderful opportunity to assess the client's availability and ability to do this. Love it. And I'll stay on just one more minute with this slide just to see if anybody else has another idea. Well, let's keep going in the sake of time, but I know your heads are trying to wrap around, okay, what would we do at our clinic? So I went back to our continuum of care and engagement and care continuum, and I showed you where I think Kay is. Aware of, the infection and receiving some medical care, but certainly not HIV care. Hence, test and treat might be a very feasible option if that's offered in our area. Might be a very significant, important change to improve the health of this individual. Let me throw this at you and let me share. From a clinician standpoint, we're building upon strengths for this client. We're building upon health. So first of all, and I'm going to try to pull down my arrow. Sometimes I'm good at it. There we go. I hope you can see my green arrow. First and foremost, as a clinician, we're going to want to look at antibiotic treatment for the individual to treat the gonorrhea. The client wants that too because that's probably what brought Kay in. HIV treatment is on our mind as well. Then we take this a bit further and we say, okay, on that we want to build safety for this client, the ability to take this medication, safety meaning can this individual take medications if they're couch surfing? What if the medications get locked up at a previous place where Z is staying and now there is no way to get the medication that was just prescribed? What stability can we build for this client? And then next comes HIV care. How do we build HIV care that's stable? And then finally, how do we engage this client so that that Z's not going around, going to different situations for care, 75 miles this way, 45 miles that way, and never having one provider or provider team that is very familiar with Kay's background and history. So that's sort of what I think many of us would be thinking in our mind as we put together a treatment plan for this client. The client, however, is probably, most likely, building upon a different structure. And I am proposing to you that Kay's hierarchy of needs may be not so stable. One, where is the money going to come from? How do I survive? Might have to pay for the couch that Z is on every day. Maybe he has to pay $5. Maybe he has to pay in a different way. Maybe it's sex for living, sex for food. We don't know yet. We haven't investigated this further. Then we look at symptom treatment. Kay wants to feel better. And then maybe Kay might be looking for safety. How do I stay safe? How do I stay on the same couch longer, perhaps? How do I rest my weary head? So as you can see, what the client is thinking and what the medical team is thinking are usually or can be very different. What I suggest is that we look at it from a different standpoint. Build upon the structure that is stable. Look at safety and stability. Look at treatment. Look at empowering the patient, starting with how great that you're here today. You noticed something was changing in your body and you sought care. Perhaps you didn't feel safe in going back to the same provider you saw before for whatever those reasons are, but you did seek care and you sought out the ability to get treatment. Good job. And then working on that engagement, because as we know from our terminology, when we empower an individual or an individual feels empowered, they growingly feel more engaged with the provider and the provider team. So if I had my way, I would give every client, like Kay, a button when Z walks through. I would say, here's your button. You are in charge today and every day, and only you can do this work, and we're partnering with you because we know you're going to need some help along the way, but you're the one that has to do a lot of the heavy lifting, and we're willing to show you every resource that we know of to work with you on this and partner with you. Again, thinking of patients as partners instead of treating them as passive recipients of care, sort of filling them up like you would fill a pail of water. We're trying to broker a relationship, a partnering relationship, and build their ability to engage in care. Person-centered care is what we're talking about, providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensures the patient values guide all clinical decisions. This is from the Institute of Medicine. Very powerful definition. We can't forget culture, and that plays out in this case of Kay. Culture influences a client's understanding of priorities about health and illness and our understanding of the client's priorities. The way people interact with the healthcare system. Culture also influences decisions that individuals make about seeking help and adhering to treatment, and it affects individual participation in prevention and promotion of health. Perhaps a certain culture doesn't even have health maintenance as part of their culture, so we're going to have to start from a different spot there. What is our clinic culture? Do we promote an experience of we're better than you to the client? Do we sit above our clients and look down at them, which might just come from sitting in a chair, as you can see in the corner here, where just being lower than the client could give that sense as, I know what I'm doing, I'm in charge, and you have to do what I say. But we know that doesn't always give the client what they need in terms of self-empowerment, because the client goes home by themselves with this information. And what percentage of the information are they hearing if they feel that the provider is towering above them and telling them what to do? Not that this happens everywhere. Here's another organizational component. That high desk where you have to rise above and look down, that may give a sense to a client that they don't want to be seen, that we're hiding back here behind the big desk. Don't talk to us unless you really are on fire. Again, we don't know. How do the consumers read our environment? How do they read our nonverbal communication? Crossed arms? These things all are important. And if you haven't considered bringing some mystery shoppers into your organization to find out what clients think of how they feel in your clinic culture, I would highly recommend that you think about that and perhaps consider it. You want to create a clinic culture that is welcoming, especially for individuals for all individuals, but especially folks that are wary about coming in. All of our staff are important to that. The folks at the front desk, the folks that are environmental control, the folks that take care of the building within which we work. Everybody's with it. The unconscious and implicit bias that's going on within our organizations, we need to find out what those are. These are things that we don't realize that are happening. They are stereotypes that we have that we're not even aware of. Again, they're unconscious. They're happening for us, and we don't realize that we're categorizing people. Not that we're thinking it, but our brains are already putting people in groups. This is like the last patient I just saw. And this is a problem because then we set up a situation where we think we know what this client is going to be like. We think we know about how they're going to act. And in fact, we really don't know until we ask. This is the bias that we're unaware of. And bias is influenced by our own culture, the environment we work in, the environment we live in, and our personal experiences. We all have unconscious biases, and it's important to know what they are so that we try to not have them and sort of, as I call, clear yourselves before we walk in to see each and every one of our clients. These are blind spots we have. We all have them. And you can go online to this website for the implicit association test and their characteristics. You can look at, do you have an implicit bias against people's age? Maybe an implicit bias against elderly people. Maybe you have an implicit bias against weight, people that are too thin, people that are too heavy. Maybe you have an implicit bias that involves race, gender, sexuality. You can go to this website and there is a test for each one. Again, a very insightful thing to do from a healthcare team approach, looking at what is going on for our clinic culture and the people that provide care, so that we are sure that we're not providing judgmental care, but in fact we're providing very open and welcoming care to our clients. The negative attitudes that we promote come from many times unconscious bias. We get the worst patients. People get what they deserve. These are just some things that I have heard in my many years of working in the area of STDs, HIV, and other diseases that are associated with different lifestyle factors. How do we overcome negative attitudes? Well, we explore our own attitudes towards people who are different from us. And we need help with that. We need our organizational help with that. We need to be reminded, just like we're reminded about how to run a good code or how to get out of the building if there's a fire, we need to remind ourselves how to provide non-judgmental care. Sometimes we go in with the thought that we're helping someone. Have you ever heard this? Well, we need to help change this patient, change their ways. Or I will share this person's personal health information with my family so that we can help them by praying for them. Or perhaps I didn't know she did that. I should tell her sister so her sister can help her. I wonder if her mother knows. Gosh, she's got two children with HIV. How sad is that? Maybe her mother should know. These are things that sometimes professionals, staff do, thinking that they're being helpful. And of course, as we know, these are not HIPAA compliant, and they are most definitely not helpful. So privacy is absolutely the most powerful thing that we give our patients, that HIPAA compliance. When a professional hears a patient's story, we're taking away a very important part of them. And if we share that information, we're taking away their power and their right to make or to learn how to make important health care and life decisions for themselves. Individuals have the legal and ethical responsibility, remember, in HIV to inform their sexual partners of their HIV positive status. We need to remind our patients of this as well, but we don't need to do it for them. And we do need to maintain a non-judgmental, patient-centered approach to care is key to improving individual patient health outcomes. Could there be a connection in how consumers are viewed and their willingness to engage in treatment? So if patients are heard that they're failures or they're impossible, they're not successful, could this affect how they feel that their level of ability to even engage in care or be activated? What promotes an engaging partnership is growing it, just as we would like a seedling, a plant. These are 3 patients. They're all growing differently. They take different types of minerals and water and light in order to grow, to feel empowered, to feel satisfied with the partnership that they're developing with their care providers. Overcoming organizational bias is a huge challenge for many organizations, and designing a bias-free organization is a very high-level behavior or activity. Measuring the bias, assessing the environment, using mystery shoppers, using quality improvement strategies that Plan, Do, Study, Act, these all help us do a better job in the work that we do. The strategies we use to mitigate bias in the healthcare setting could involve hiring a diverse healthcare team, creating healthcare work environment that embraces cultural diversity, challenging stereotypes, talking about this regularly So just to remind ourselves, and that quality improvement piece, not being quiet about it, but being active and engaging in the conversation to remind our coworkers that we're about non-judgmental, confidential care. So this bias that we all have is very important, even our organizational bias that we can measure, very important to this process of self-management and activation that we're talking about today. If we look at a comparison of the paternalistic and empowerment models in providing health care, I would like to see all organizations reach for the empowerment model, not the paternalistic, telling patients what to do, but empowering clients, that mutual sharing of knowledge and information, strategizing together. What's the next step? Kay, you did a great job by coming in today. You're uncomfortable. What else is bothering you right now? What thoughts do you have about your HIV care? What was the plan when you first found you were HIV positive? What happened to that plan? Or maybe there was a lack of plan. That's okay, but what is your plan today, and how can we assist you? So cultural leveraging be what you do in your organization to create and meet the needs of all individuals living in your community. Say someone that walks in your clinic like Kay. How do we do that? Well, maybe we have access to a mobile health unit or another clinic that would be more convenient for Kay to go to that would be a step to engagement and care. Maybe we have even in weekend hours that would involve Kay getting into a different time period of getting into clinic. And expanding that definition, what is Kay's health literacy? How do we approach that? And more important, part B of the definition, which I love, is not only about the patient's ability to obtain, understand, and act on health information, but it's our ability to communicate clearly, educate, and talk to clients about health and empower them. So we have an important role in health literacy. It's not just what the patient brings to the table, it's what we bring to the table. And we can always better ourselves because I'm always learning a new way that I could communicate better and educate and provide advice to clients after I ask their permission for that, to give them advice. And I do that by using the REAP, R-E-A-P method, by respecting, here we go, by respecting, empathizing, affirming, and partnering with the clients. And I do that using motivational interviewing and trauma-informed care. We want to use people-first language. A person is not their illness or their lifestyle. A person is not MSM. They're a person who has a lifestyle that maybe is MSM. The person is not HIV. They're not an old person. They're a person that has had many birthdays. Again, a person is not their illness. They are a person first, and the things that they're challenged with, which all of us are challenged with something, that comes second. Empathy is important, and I think it comes very clear in the topic of today is that we have to be able to see an individual's world and appreciate them as human beings, as people without showing judgment, trying to understand their feelings and communicating that we hear what they're saying and we understand their feelings. Motivational interviewing is a great tool, not the only tool, but a great tool to empathize with clients and help guide them moving forward in their plan of care. It focuses motivational interviewing on the intrinsic value, what the patient internally feels is their sense of finding their motivation, not my motivation for them, because my motivation is always high. I want the best for all my clients, but what is their motivation? How motivated are they to change a behavior? How motivated are they to feel better or to be well? This description is all about active listening. And when I did a word cloud with one audience, they said eye contact and trying not to solve the issue for the clients, showing empathy, having some uncomfortable pauses to allow the patient time to talk, restating what we hear, to check back in with the client and say, I think this is what you said, but let me check in with you and make sure I understand clearly. Oftentimes, open-ended questions are really powerful in working with our clients who have limiting thoughts. A limiting thought, for example, is a client that says, my mother's an alcoholic, doc. People say I'm going to be just like her. I'm going to be just like her. Instead of just nodding our head like, I see, I understand, what if we asked the open-ended question, if you could be different than your mother, what would you do with your life? This has the client entertain the idea, okay, I get that you are thinking this, but what if? And sometimes some great, powerful things are learned in this conversation that we can reflect back to the patient, that we heard something really powerful. Oh, you'd go back to school. Oh, you'd be a teacher. Oh, you would work in the field of drug addiction. Boy, that's powerful. Wow. Do we need people in that field today? That's a powerful thing you just said. Using affirmations. We can provide affirmations to a client, such as we can say to a client, this is hard work you're doing. Coming back for a second visit in a row, that's tough, considering that you're not stable with your living conditions as of yet, but that you're working on it. Even higher level is when a client says, I can do this one step at a time. And sometimes when we use open-ended questions, we can work it that a client actually is the one that sets their own motivation. They set their own affirmation. They pat their back on their self, and there's no higher powerful thing happening for a client is when they pat themselves on the back, because again, they go home and they're on their own, and they've got to learn how to pat their own back, saying, I'm doing the best I can, and I am taking baby steps forward. So some clients need to learn how to give themselves an affirmation, because many of our clients are under stress. They've been traumatized and under distress. They feel shame. They may feel inadequate. They have maybe rejected themselves because they've been rejected by others, and maybe they're very depressed, anxious, and maybe they're using self-medicating different medications, legal and illegal, in order to feel numb, to not feel anything, because it feels better than feeling shame, inadequacy, rejection, depression, anxiety. I recommend that many of our clinics look at distress assessment. What is happening between visits? This is a great tool, and it was pioneered actually in cancer treatment. And again, you do have the site where you can get this, and this can be printed off very quickly. Checking in with clients, and it looks at practical problems, family problems, emotional problems, and you can look at this and see changes, and you can also see not only negative changes, but you can see powerful positive changes, which allow us to sort of get back with the patient and say, wow, I see a huge change in the fact that you are not feeling depressed right now, and you're not feeling as fearful. Tell me what you did to change that, because last time you were here, you felt really sad. The David Neal and Wendy Wood in the Journal of Personality and Social Psychology did an article in March of 2014, and it was on stress and health-related behaviors, and their findings were that people who regularly ate unhealthy foods went for more junk when they were under stress. But people who were good eaters, essentially A+ eaters, kept up the pattern even during distressed times. So the conclusion these authors made was that stress tires the brain. So health behaviors that take the least mental effort are the ones that are employed during times of stress, meaning we revert back to things that are easier and take less effort. So remember that engaging in new behaviors is really hard, and sustaining them even harder. And we want to talk about this with our clients so that we can broker, hey, what will happen if you have to go back, if something happens and you go back to couch surfing? How will this affect your stress level? And how will that affect your eating? How will it affect your ability to take your medications? As I said earlier, providing trauma-informed care is very important as a key factor in addressing the healthcare needs of our clients as we move toward working to help them activate in engaging in their own care. We want to create that safe and sensitive environment. We want them to know that our organization serves diverse, inclusive, we're accepting, we're welcoming. We provide safe space for everybody who opens these doors. Sometimes we need to see more than just someone at the front desk. We need to see other people in the waiting room. We need to see the way the chairs are set up. And there are people like myself who can help with this, looking at waiting rooms, bringing consumers in and saying, this is the way your waiting room feels to me. And here's some suggested changes that might make individuals feel more welcome and more accepted in your environment. As we said, stress is a huge burden, and many people, as well as providers, we carry that on our backs just as our clients do. Our clients walk in like this, carrying it in their back, and so do we. And vicariously, when we hear the traumas and the lives that some of our clients live, we carry their stress with us. We call that vicarious trauma. So what do we do for that? We've got to team up individually as well with our peers, with our friends. We don't have family members, but we've got to do something. One way is exercising. We can meditate, and we have very good evidence now that different types of meditation, offering that in our clinics, having a quiet space where clients can go, a ready room where they can go between being in the waiting room and going into the provider clinic. I often offer that as a possibility. Do you have a space, a small space that could be a quiet room that would, just like we do if we go for a massage, where you sort of chill for a minute and you have decreased distractions and a chance to settle yourself and practice that. So in summary, engagement in HIV care is increasingly recognized as a critical step in maximizing health outcomes for people living with HIV. We recognize that we can get stuck in practice patterns because of our unconscious bias, because we see so many patients in a day, and we feel that we don't have the kind of time we need in order to give the client the time that they need when they come in with so many challenges. And it takes energy and a very good plan to change our practice behaviors. But again, that's quality improvement at its very best. And thirdly, people living with HIV have the capacity to live long, healthy lives. We know this, but our clients and their families and their friends may not know this. And so we want our patients to partner with us, and we want to do everything we can to be good partners to our clients and be part of the healthcare team that help them move and develop their ability to motivate themselves, to use their internal motivation and the skills that they're building slowly to have undetectable viral loads. And with that summary, I want to jump into a think tank or a short question answer. What, based on everything we've talked about, what I've presented, what I've shared, what will you do by next Tuesday to improve engagement in HIV care in your clinic or practice? And I appreciate my tech team here behind the scenes and all the work they're doing to keep up with your questions that I hope you're typing in, and the short answer questions that I'm asking of you. Because if you have something that you're willing to do by next Tuesday, that's an amazing start. Maybe you're going to look up one of these tools. Maybe you want to look up at the Barrel Institute and see when they're going to release the tool of activation, because maybe this is something that you could do and implement. Maybe it's going to be simple that you're going to put up a poster in your waiting area that allows people to feel more welcome. And I'm seeing that answers are popping in. Thank you so much. You're going to ask clients what they're willing to do to address their HIV plan. Wow, great open-ended question. I couldn't be more excited about that question. Great question. What are you willing to do? What are you prepared to do? You're going to share these slides with your coworkers. Super. I love it. That's doable by next Tuesday. And if you're going to do it tomorrow because you got a case conference tomorrow, by all means do it. But I hope that these slides can give your team and your colleagues and you more information and more ideas. Remember, quality improvement doesn't have to be that you're changing your whole organization. You could change something for half a day. Implement one change, like changing the seating arrangement in your waiting area, and do it just one day on Friday and see what happens. And that could be quality improvement at its very best. It's taking something and changing it, tweaking it slightly, and seeing if anyone notices to begin with, and doing a little survey, because that tells your clients that you're changing, that you're trying to meet their needs. Those things are very important for clients to know. That would be like me going to a foreign country where I don't speak the language. If I try to communicate, try to use a few words, I'm most often going to be well received. So let's ask you another question. Thank you for those folks typing in. I appreciate that so much. I think I have another question for you in the next slide. And that next question is, what information or training do you and your organization need to empower, engage, and activate your patients living with HIV so that you can move through these processes I've described? What can we help you with? Or, what maybe this might help with future webinars or future types of trainings that we can provide to you. How do you best learn? I'm an engaged learner. I like having discussions, and even on a webinar, when we utilize these open-ended questions, we can try to have a conversation. So what additional training would you like? Would this be a powerful presentation to present at one of your staff meetings, for example? Sometimes we can do this remotely and put this up and have a conversation, show the slides, you show them at your organization, and then I can get in on the last 15 minutes and help facilitate a positive conversation that looks at quality improvement and what are the next steps. So if anyone has anything they'd like to type in, either on this question about what further information you would like to have for your organization or you, or maybe a question about this presentation, something you saw that you didn't quite understand or you'd like more information about. And a great answer here to my question on what do you need, cultural sensitivity, overcoming stigma, motivational interviewing, customer service. Well, we want to help you with that. Thank you so much for putting that out there, and you are not alone. And I know that my tech team can connect with you, and we would like to help you. If we're not the ones we can certainly send resources. But if you think one of these topics that we can do in some sort of live or telehealth format, we certainly would like to discuss that with you and partner with you from the AETC, the Southeast AETC, as well as if you're one of our wonderful states in the Southeast AETC, or whether you're from North Florida ATC or the South Florida ATC, no matter where you are, even if you're from the Caribbean, we want to work with you because, again, we serve you and we know you're in the trenches, and we want to partner with you to understand what your challenges are. A training where participants can safely, comfortably explore their biases for different client groups living with HIV. I totally support that, and I know we would like to help you with that. I think that's really important, and I have a few clinics that have raised their hand and said, please help us with that. And I really applaud the fact that you're one of those clinics that is raising their hand. Please let us know how to contact you if we don't already know, and I'm just putting word out there to the tech team. please send us anonymously somehow, or even in the chat room. Tell us how to reach you so that I can call you personally, or Taryn, our wonderful coordinator who's just in contact with everybody, can make sure we get to you and make sure that your voice is heard, and we can broker something with you in order to help out. Utilizing retention tools. Cool. Well, look these tools up, and if you decide that you want to use one and you want a little help, or you want a little bit more information, or you just want to bounce it back off someone that is not only used some of these tools but has a pretty good experience with using QI, then please feel free to contact me. I think, Taryn, on my next slide I do have some contact information. Thank you so much for really doing the work of typing in. I know that's just an extra piece of all this, but this is that moment for comments, questions, aha moments, and again, my contact information to you. And I certainly will stay on the call. I know Taryn needs to also summarize and give you some information, but I will stay on the call to answer any questions that you may have if you can stay on. Thank you so much for inviting me into your training rooms or your phone or wherever you're listening to.
Thanks, Deb. As a reminder to everyone who's on the line, a copy of today's PowerPoint presentation can be found on the downloaded, you can download them from the Files pod on the bottom left-hand side of the screen. And remember, for those of you who need continuing education, this course is approved for 1 credit hour through the Florida Board of Nursing and the Florida Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling. We will report directly to CE Broker through those boards, but please complete the evaluation link. You should have already received that in your inbox. It's also here on the bottom right-hand side of your pods. It says evaluation link. If you double-click that or press the Browse To button, it'll take you there. Once you complete that evaluation, you'll receive a proof of attendance certificate that you could print and store with you immediately. If you have any other questions, feel free to respond to that email address that you got all the contact information from for today's webinar. That's the best way to get a hold of us. And if you have any specific questions for Debbie, you can put them here in the pod, or again, you can send them over to Debbie's email. She's got them listed here, or respond back to that email that you got today with your questions, and we'll make sure we get them to Debbie.